Good afternoon, everybody, and welcome to the very next episode of our COVID-19 series from the Royal Society of Medicine, very kindly sponsored by Stephen Gilbert, one of our trustees. And today we're going to address the issue of the impact of COVID on surgeons, on surgery, on the surgical waiting list, and of course, on most importantly, on our patients. And we have a very interesting panel today. We've got three generations of surgeons. Starting with the most senior, we have Derek Alderson, immediate past president of the Royal College of Surgeons. In the intermediate position, we have Ben Challacombe, consultant urologist at Guy's and St Thomas's and an expert on robotic surgery. And then last but not least, definitely not least, we have Hannah Warren, who is a trainee surgeon at King's College and in the thick of it, as it were. So actually, why don't we start with Hannah? So Hannah, you've kind of lived as a trainee surgeon through this COVID crisis, and you'll know how difficult it has been to perform surgery in these circumstances. Do you want to just tell us a little bit about how it's actually been for you and for King's?
Well, yeah, it's obviously been a huge challenge and a really kind of, unique once in a career, hopefully, situation. All of our clinics, the majority of urology services, and urology is my specialty, lots of it is an outpatient specialty, and all of our clinics have shifted from face-to-face to telephone and via video conferencing. And that really raises challenges, not being able to meet your patient, not being able to speak to them face-to-face, not being able to examine them. That's been a real challenge. And making decisions in that context is a worry, because you worry about missing things that are important, misdiagnosis. It's just not an environment that we're used to and trained to practice in. So that's been a challenge. Initially, we had big problems with kind of just organisation of services, PPE. We had patients coming into the hospital, catching COVID while in hospital. And the guidance kept changing, seemingly like every 5 minutes. We didn't know what we needed to do to protect ourselves. Within our department, most of the registrars contracted COVID-19 in the first few weeks of being in lockdown. And that has issues for staffing, clearly, and also concerns about everyone's health and well-being. We've seen waiting lists increase dramatically, not just for benign disease, but for cancers as well. So those are lots of the issues we've faced. From a training perspective, because obviously I'm in surgical training, the last 6 months have been something of a write-off in terms of making progress. And we found ourselves having to be really creative about how we make the most of this time, because it delays our progression through training. We worry about losing the skills we've been gaining. And that's been a real concern for trainees, keeping up operative skills. All the exams have had to be postponed and cancelled. So again, that's another thing that's stopping people progressing through their training and career pathways, because it's just not safe to do those face-to-face assessments that have been developed over generations. So those are the main points.
You were telling me before that urologies are kind of below the umbilicus specialty, and there are particular difficulties in doing video consultations in sensitive scenarios. Just expand on that a little bit.
Precisely. Even this morning I was running a clinic and I was referred a patient with problems with his foreskin. And you find yourself making a decision about whether you ask them to get their penis out on a video conference so that you can examine what the problem is, or do you risk bringing them into a hospital to do a face-to-face examination? It's a real challenge, and it's just, you're trying to remain professional, and asking someone to show you their foreskin on video conferencing is uncharted territory.
Ben, let's go to you. Could tell us the scenario at Guy's. I mean, Guy's Thomas's is an enormous unit. It's probably one of the most famous urology units in the UK. So how's it been for you?
Well, I mean, as a trust, of course, we have the unlikely distinction of having the most COVID cases in the country. Of course, we looked after the Prime Minister at Thomas's, and they seemed did amazingly well. So, yeah, we on both sites were absolutely decimated at the beginning. We did essentially no elective surgery for April and May. One of my roles is in part of BAUS, British Urology Surgeons. So we tried to get together. I think we did quite well compared to some other specialties. We had our guidelines out for prostate, bladder, kidney cancer, testis and penis cancer, all of our main disease groups within the first couple of weeks of April, to allow everybody to kind of work out how we were going to do this. And we pretty much put prostate cancer on hold for 2 months and carried on with kidney and bladder cancer in my specialty. We formed an alliance, a network. We worked out of the HCA private hospital. We had a committee set up that would, rather sadly, difficultly, would have to go through the limited number of operating lists and work out whether a bowel resection was more important to do this week than a lung cancer, than a bleeding kidney tumor. And people were amazing, actually, in sort of in accepting the availability. And obviously now we're getting back to, we've had a period of getting back to normal. The benign disease aspect, so obviously in my specialty, that involved continence operations, operations for enlarged prostates, operations on the genitals, reconstructive operations. They've not had much space at all. And that's been awful for the patient groups involved with that. So there's lots of men with catheters, certainly I know of in Southeast London, hanging around desperately waiting for their operation. And I think one of the big things that we're going to look at if the second wave becomes a major factor is trying to keep going, trying to keep many more things going this time round than we did last time. So thank you very much for inviting me along today, Dr. Kirby. It's been nice to join the panel.
Well, thank you. I guess kidney stones too will be an issue because they're benign, but of course people can get very sick with an obstructed, infected kidney stone. In fact, it can be life-threatening. So, Ben, before I go to Derek, and we'll talk a little bit about the college and exams and kind of college guidance for the way ahead. I mean, how did that panel work? So you got like gastric surgeons and lung surgeons and urologists and cardiac surgeons, all kind of fighting for theatre availability. So was it done in a civilized way? I mean, to some extent, you're playing God with the patients in deciding who gets treated and who doesn't.
Oh, absolutely. I mean, we came up with some ground rules that basically meant no one person would be in charge of deciding that somebody didn't have an operation that was ultimately going to lead to their demise. That would be we're good at MDT, so that was going to be a team-based thing. But I think within a couple of weeks, we realized that it was actually more sensible, rather than the committee trying to decide who goes first, to say, right, colorectal, you've got 4 lists, urology, you've got 3 lists, thoracic, you've got 3 lists. You put the cases on that you think are the most important for your specialty. Let's let sensible professionals decide their own order of priority. And then we looked at the usage, and in the end, urology, we had 8 or 9 all-day lists a week at HCA, which was enough to do our cancer work. We have not got a backlog for bladder or kidney cancer. Our most lethal cancer is coming out at the end of this. So I think people worked out that playing God, which was only there for a couple of weeks, was not a sensible thing to be doing.
And we had on this program a few weeks ago, we had Steve Edmondson, the cardiac surgeon at Barts, saying that they got a system of a sort of COVID-free system. They were testing, swabbing the patients and putting them into quarantine, and they managed to get through quite a lot of cardiac surgery without, I don't think anybody contracted COVID post-operatively, which everybody was worried was going to be terribly dangerous. Did you see that? Did any of your patients contract COVID as a result of coming in?
So yeah, I mean, there's been great audit work from the team, actually, at Guys and Thomas's, Johnny Olsborough, head of our audit, Kate Hare, who's been head of our this committee, have actually looked at it all. So we met as a group every week or every other week. I met as a group of urologists throughout London, because we needed to know if people were dying of radical prostatectomy or cystectomy in the north of Thames. If someone had a death, the rest of London needed to know. So it was amazing for the sharing of data of off the, really off the edge of the admissions data, So we had 2 people who caught COVID post-operatively from thoracics and ENT complex operations at the beginning. That was in March, and 1 died. I think that they had a highly complicated situation. And at that point, we brought in the 2-week self-isolation. We brought in the preoperative testing that was done a day beforehand. They were admitted a day before. And since all of those measures were brought in, touch wood, we've not had another major issue. We've picked up some people who've had COVID on admission, who've then been deferred, but we've not operated on anybody with positive COVID, and we've not had anybody pick it up post-operatively. Yeah. So the system was then worked.
So Derek, tell us then, I mean, as I said, the college has gone through tremendous, Royal College of Surgeons, gone through tremendous disruption during your presidency, but especially since March. So, I mean, what is the college's position in facing now a waiting list of, I think some people, it's millions and millions of patients who are on the waiting list. So how do you think we're going to address this issue?
Well, I mean, you know, the sad fact is that we've got more than 2 million people now waiting for more than 18 weeks, which is, you know, the government's target to get people treated in. So, I mean, we're at a level that's unprecedented. It's worse than it's been ever since we started keeping records on that basis. The harsh reality, of course, is that many patients will have worse outcomes than they should have had we not had this crisis and had not had this delay. Ben has mentioned this in benign urology. The man who's going around with a catheter in is unlikely to get as great a result as he would have done if he'd been treated promptly. Enormous numbers of people with orthopedic problems, which just about stopped in some parts of the country, who are in pain, unable to work, lost their jobs, greater disability, dependent on narcotic analgesics. So, you know, the scale of the problem and the broadness of it is unprecedented. We've never had to deal with anything like this. So getting out of it, a solution, we obviously have to look at really quite radical changes in the way in which we deliver surgical services. In the beginning, of course, this has been the creation, as Ben has mentioned, of what we call COVID light or COVID-free sites. We'll need to, as it were, consider in a much better way strategic changes in the way in which we deliver complex surgery and benign surgery within regions, within geographies, between trusts that historically have competed with each other. They're going to have to form alliances to be more efficient and to see more patients treated safely. And then, of course, we've got this enormous problem, as Hannah mentioned, of the detrimental effect that this has had on training. And we obviously have to get training going again. People have to be exposed to simple and straightforward procedures before they can graduate to more complex operations. And it's the simple stuff that by and large has not been done throughout the crisis. And this means we need more capacity and a different way of looking at training. And to some extent, some of that additional capacity for surgery will have to come from the treatment of NHS patients in the independent sector. And I'm pleased to say that the college has led on this right from the outset. Even before the COVID crisis, we realized that this was something we would almost certainly have to do anyway, because of the rising numbers of patients on waiting lists before the COVID crisis. And substantial progress has been made with the independent sector providers to look at how we can create a sustainable system that allows our trainees to access the NHS patients having straightforward operations, elective procedures in a COVID-light environment, usually also in many cases in an independent facility. And there have been many challenges that have had to be met in order to do that. One of the ones that obviously concerns the trainees is the issue of indemnity. How are they covered if they're working in that environment? It's not their usual NHS place of work. and we've made substantial progress in being able to cover that off. There are issues, of course, about rotas and how people will be able to provide decent continuity of care. We know that many places rotas are difficult anyway, but that's one of the reasons why we have to look at almost a reorganization of the disposition of our surgical services in order to have safe rotas and provide continuity of care. So the college has been heavily involved in that. I think that substantial progress has been made. In some parts of the country, we have pilots running now to look at how it can be delivered. And I suspect that that's one of the ways in which we will begin to restore surgical services to an adequate level. All of that, of course, is predicated on us not running into an enormous second wave, or indeed a major flu epidemic this winter that would inevitably impact on our ability to deliver elective surgical services. So it's a difficult time. We're still in a period of great uncertainty.
Yeah, well, Michael Kenworthy Brown's pointing out, I imagine he's an anaesthetist, that of course, you know, the problem in surgery, it can't only be dealt with by surgeons. We need our anaesthetists to help us out with this as well. And the anaesthetists have taken the brunt of this pandemic, really. They've ended up in ITU wearing masks, and they've had to work like hell. So we should never forget our anaesthetic friends and colleagues. So let's go back to Hannah. Hannah, tell us a bit. You know, you're a trainee, and I remember many years ago when I was a trainee, the number of cases that I actually did myself, I got in my little book, terribly important to me. So I imagine that this is impacted badly in terms of practical training for you. Is that right?
Yeah, you're quite right. So we keep logbooks of all our operating activity in order to help us reflect and learn on the cases we've seen and been involved in. And pre-COVID, my logbook was looking at around 40 cases a month that I'd been involved with or performed. And during the April and May, really, which was when we really felt the impact massively, that dropped down to 10 a month. For those months. And that was with me being quite creative and trying to find opportunities, traveling to other centres that still had some activity going on. Because as we've heard, COVID kind of cold sites were set up. So patients who'd been in isolation or screened for COVID preoperatively or pre-procedure were going into COVID cold centres, and I managed to access some cases then, but we're still looking at less than a quarter of what I had been doing previously. Now, more recently, as we've seen things have slowly returned to something close to a level of normality, in the last 6 weeks, I've been doing closer to the 40 procedures a month. But, you know, the future is very uncertain, and I don't know how long that will continue. As we've heard about, relying on the independent sector to provide capacity to get NHS patients the procedures they're waiting for. And that's great, and that definitely needs to happen. But trainees aren't always able to work in those independent sectors. There are established consultants who already work in those centres that can take their NHS work there. But so far, I'm not aware of any trainees who've been able to access those opportunities. So that's something that needs to be addressed as well going forwards, if that's going to play a major role.
Yeah, thanks, Hannah. In a minute, I'll come back to you, Derek, and ask you about exams, virtual exams as opposed to physical exams. But there's a question that I want to put to Ben from Amanda Saunders. Amanda says, most impacts of the current situation are negative, but have there been any positive outcomes that you think will help patients of the future? I mean, you're in a unique situation because you're a robotic surgeon. You can use dual consoles to train trainees and so on. So Ben, tell us, say something positive to Amanda.
Yeah, no, absolutely. Where there is a hardship in humanity, I mean, we find a way. And yeah, from the point of view of the teleconsultations, for instance, I do a lot of kidney cancer. People come for scans. They come from miles around for their scan, and they come back a week later to see me. Why are they coming back? They don't need to come back. I can just ring them. So we've streamlined things that we will keep going in the future from that point of view. And the same is true for follow-up after prostate cancer, where they need a blood test. They can have the blood test done anywhere is easy for them, and then we can liaise. So we were worried that giving people a new diagnosis on the phone would be a really bad thing to do, and that it was not the right thing to do according to our training, that we should be there and ready to support them. But actually a patient told us, actually, to be honest, one of the worst things was walking out through a packed waiting room, having just heard the news and having to face all those people in front of me. I just wanted to be at home with my husband and cuddled up. So we actually thought, well, we can do some of this work as well. So from the clinic work, I think we will carry a lot of things forward that will make us better and more efficient and allow more time for the people who do need to come up. Positives from the operative point of view are, I suppose, we've done one thing that comes to mind is we did a case of a advanced testis cancer for a man. We didn't have any experience of doing a specific technique. We did it in one way. We wanted to try to just do it in a different way. We've used tele-mentoring, tele-surgery, if you want, for another surgeon to jump on not a Zoom, it's a system called Proximie, which allows surgeons to kind of watch each other, draw on the screen. And we used Proximie for a colleague in Seattle called Jim Porter to help Archie Fernando, one of my amazing colleagues at Guy, to do what was a really difficult operation. So the patient ended up with a better outcome because we were able to do it in a more minimally invasive way because of the fact that we kind of connected on a link. But yeah, there are the point about the training is one that is really difficult. It's made me think about trying my hardest to give as much training as possible in the cases that we do have to the trainees, knowing the story that Hannah has said, which I think is similar to many trainees in my unit as well.
Well, Ben ran a fantastic series of webinars for urology trainees, which through the RSM, which are very appreciated. Derek, there's a question about indemnity. So just how is that going to work? Will that work in the devolved nations? What our listeners is asking, and then go on to tell us about how, I think, is it last week you had your first virtual FRCS examinations?
Yes, my understanding is that negotiations, I haven't been involved in the last month or so, but before that, when I was still president, we made substantial progress. I think there was an acknowledgement in the Department of Health that NHS patients treated outside NHS facilities, that arrangements could be made for the usual indemnity that occurs in the NHS. And I understand that those arrangements are proceeding, and that it's likely that there will be a satisfactory system in place to ensure that indemnity, as far as the surgical or medical staff are concerned, is the same in both sectors. The whole idea of these negotiations is to really harmonize the arrangements between the two sectors and to minimize some of the differences that exist between the NHS side and the independent side. I might just say just something very quickly, Roger, in passing about lessons learned.
Sure.
Before, I mean, I think there's two really important things. The one is that I sincerely hope that the medical profession and the people who are frontline clinical staff, that there is a realization that they stepped up to the plate without a lot of administrative bureaucracy, made changes in the way in which they had to conduct their practice in their hospital, and did it extraordinarily well in the vast majority of places. And if there's one important lesson I think that can be learned by all doctors particularly, is you can lead this NHS and you can make changes and you can make them rapidly, and you are not dependent on innumerable tiers of, let's call it, other managers to, as it were, lead the health service. The medical profession should have learned that they've gone and done it under duress, and it's been very successful, and we should continue to do that. The second thing is that within the profession, the senior people, folk of my generation and somewhat younger, go around saying that junior doctors are not as committed as we were in our day. And if one thing has dispelled that myth, it's been this crisis. All of the surgeons and anaesthetists, for instance, in training, have moved into other jobs that they were not, you might say, previously trained to do, put their shoulders to the wheel, and have performed well beyond anything that was expected. They are every bit as committed as we were in our day. Yes, the jobs are a bit different, but please, I think that that accusation never had much foundation, and we surely have learned from this crisis that it actually does not apply. They're just as committed as we ever were, and we should just acknowledge that. They're different, that's all.
Well, I can tell you that Hannah is no way a snowflake. She's the opposite of a snowflake.
I don't think any of them really are, to be honest. That's a small minority of people. I think.
Just go on now to tell us about the exams.
Yes.
A lot of people worried that their training, not just their training, is being delayed because they're not getting the cases, as you heard from Hannah, but not going to be able to get the exam, so they're not going to be qualified, they're not going to be able to apply for consultants. Yes. Big worry.
Yes. So, of course, we've had a moratorium on exams that now is 6 months. I know that for the intercollegiate examinations, those responsible have developed a comprehensive program to, as it were, catch up in the end of this year and in the next year. Of course, we've had to move to a modified examination system and program. I think the first series of examinations has now taken place. I understand it was conducted satisfactorily. Of course, again, one of the things we've had to learn from the crisis, and as it were, thinking ahead about the way in which we used to conduct our examinations in surgery, particularly, we're one of the few colleges, the surgical colleges that is, that still rely on patient encounters as part and parcel of our exams. I know that not all surgical specialties do that, but we are looking very seriously at whether or not that really will be sustainable in the future. And other colleges have moved away from it without apparent detriment. And I think that, you know, we shouldn't describe ourselves simply as outliers, but I think that it needs very serious consideration. And, you know, to what extent can you replace direct patient encounters with simulations? To what extent can you make evaluations in the workplace instead of exams? How much are we looking at competency-based assessments as opposed to our old-fashioned examinations? So again, these are lessons that we've had to, or issues that we've had to face very rapidly during the crisis, and which, you know, I think will produce changes over the next few years. I appreciate the issue of having to catch up. It is very difficult, and we must, you know, achieve that catch up and make sure that people are properly qualified to start their consultant careers to a standard that is not diminished in future if we have a different system of assessment. There's no reason why it should be diminished, but we just have to ensure that it is so in order that the public should retain confidence in the surgical profession.
So let's turn to Ben. Ben, you're working with all sorts of different specialties, surgeons who are pals of yours. I mean, I imagine that orthopedics is going to be the specialty most badly affected because they're dealing with benign disease and there's no enormous time pressure to get joint replacements and backs done. well, I suppose unless they've got a disc or something that's compressing the nervous system. So, well, tell us what your colleagues are saying. I mean, a few of my friends who are orthopedic surgeons are going crazy. They're just twiddling their thumbs, not doing enough operations. They really hate this current situation. What's your view on that?
Yeah, no, Roger, I think you're quite right there. You know, the reflection in my own specialty, there's 22 of us at Guy's, and you know, 10 or so are cancer and 10 or so aren't. And it's been incredibly depressing in a way for you know, these are people who've built up tertiary referral practices over many years. We're even discussing, you know, should we be accepting any tertiary referrals at the moment for complex reconstruction? You know, the same would be true for the orthopedic people doing, colleagues doing, you know, revision hips, or, you know, complex arthroscopic work, things that are just not going to get there. And of course, this sort of work does lend itself hugely to going into these hubs, these independent sector hubs. I know we're setting up some of these in London, that they're going to be based in some facilities that have capacity to do relatively low complexity, high turnover operations. My worry as a trainer, I run the fellowship program for us in robotics, is exactly the same as Hannah's worry there, is that if we take all the ASA 1 and 2 patients off for hernia repairs, and we knock out 8 a day on a list in a small private hospital, and the only patients who come to the bigger centres where the trainees are the complex ones, there's always a reason why the trainee can't do that operation. It's a bit too difficult, it's a bit too late, they need a quick operation, etc., etc. We've heard all those excuses. So I am concerned about how we're going to deliver that. I mean, I'm mixing mainly with the oncologists, of course, and seeing it from fellow oncologists. I'm having a look at some of the questions there, Roger, about thoracics, which, I mean, I would agree that with the concern of delayed diagnosis, I really wanted to get that across to everyone.
Question from Jeanette Rawlinson, you know, pointing out that lung cancer, really rapidly developing cancer, where the window of opportunity to cure is very, very small. And of course, you know, the other issue is not that when the patients present, it's difficult to get them operated on, but they're not even presenting. So I think you were telling me that you're seeing, you know, stage testis cancer and other cancers at a higher stage, a more advanced stage than you did before the crisis.
Yeah, I mean, absolutely. I mean, the logic that me and the colleagues are working on is that, you know, the more aggressive cancers are likely to be the ones that show the stage migration the earliest. We're seeing that in testis, young men who've metaphorically sat on things for a few months and then presenting with metastatic disease at rates we've not seen before. My worry is that will come through in the other cancers, kidney and bladder. And, you know, I think that we all need to be part of almost a national campaign. I've done a couple of urology related pieces, but just, you know, if you have a symptom that could be serious, go and see your doctor. Come in. We have not got a problem with diagnostics, biopsies, scans. We've not got a backlog for those at all. And we are there, you know, as the NHS to try and look after these people, whatever their problems are. And they may be much higher risk to them than COVID. Even though we're going through a second pandemic, you know, we could easily, you know, try and eventually win a battle with COVID, and, to give a catchphrase, lose the war with cancer big time. And I think we need to just encourage everybody to go and get checked, and because these secondary surges of cancer will come, unfortunately.
Go and get checked, even if it means taking your trousers off in front of Hannah on your computer screen. That probably is a bit alarming thought. Hannah, let's go to you. And you know, it's no question the second wave is coming. And really, I suppose what'll be different about the second wave compared with the first wave is at least we'll have some tests to tell who does and who doesn't have COVID. And of course, it's all over the media this morning that testing is insufficient for the numbers of people requesting a test now that the kids are back at school. But I mean, would it make a huge difference to you in your practice if you could have a point of care test that the result would be back in 20 minutes or so? Does this patient have COVID or not? Just talk us through that.
I mean, I think the future has to be in testing, and got to commend the government on making that their plan to really massively expand their capacity for testing. Until now, any patient who's been waiting for an operation, the deal has been for them to have their elective operation. Both them and their households have to self-isolate for 2 weeks. At least in my trust, that's been the policy, for them to be able to have surgery. And if they turn up on the day and they haven't been doing that, then they would be cancelled. Now, those operating slots, of course, are very precious given everything that's going on. So particularly in my area in South London, it's quite a poor area. Lots of people working in hospitality that's seen obviously a big crisis in employment, and people are terrified about being able to keep their jobs. So it's a big ask to ask someone and their whole household to self-isolate for 2 weeks for someone to be able to come and have an operation. So if you're able to reduce that burden on patients and exchange it for testing, then that's the way forwards. We're currently in the process of switching to patients having a COVID test 72 hours before their operation date, and then they just need to self-isolate for the 3 days between their test and their operation, which we're seeing a lot fewer on the day cancellations because of people not having self-isolated. So I think the future has to be in testing, but that relies on the tests being good enough that we can rely on the answer that they give us. So if they're not sensitive enough in picking up those COVID tests, then obviously the positive COVID people, that obviously adds a risk.
There's one other question for you, actually, from Sachev Sayan. He says, could some comment be offered on how consultants, how doctors have involved family and carers in the patients when they come in? Because that's a big worry for people coming in, particularly for a big operation, one of Ben's famous cancer operations on the kidney with the robot, which is risky business. So both Ben and Hannah, how have you kept the family involed? And
Roger, I've got a point on this, which is I think what that question is getting at, and really important, which is if you sit down and speak to the patients about their admission and their process that they're going through, one of the most miserable things is that they don't have any family support there. And you and Prakash Gupta taught me 20 years ago about the benefit of phoning patients' relatives after an operation. And I always do that without fail, make an absolute special effort to phone the patient, some patient's relatives, sometimes more than once, give them an update. I actually do a thing where I put them on FaceTime in recovery sometimes so that the relative can see the patient can say hello to their own and hear the voice, because sometimes they've been in hospital for a couple of days beforehand. And my mum's listening. She's in Turkey at the moment. She's in a GP. She'll be pleased to hear me. Something's rubbed off on me from her knowledge about the importance of that holistic care to the family, of making sure that you keep them up to date, because it must be so terrifying to go through these situations on your own in the hospital with everyone with masks on.
So it's getting near the time we have to finish. Derek, any final thoughts? Actually, I want final thoughts from all three of you, really. So Derek, is it doom and gloom for this winter, or what's your prediction of how things are going to go? You're up in Northumberland. You're 3 miles south of Hadrian's Wall. You're on the right side of Hadrian's Wall, some people would say, or maybe actually the wrong side these days. Who knows? But let's have your final thoughts.
I'd like to think that we have isolated outbreaks that we're able to control through testing and tracing in an adequate way, and that we're able to maintain reasonable surgical services throughout this winter. I think we're going to have to look as imaginatively as the profession can at ways in which we can sustain our surgical services, maintain COVID-light sites in order to try and at least do, as Ben says, the complex surgery. And I think with a fair wind, enough change has occurred and we have enough things in place and experiences learned to be able to, as it were, sustain things over the winter months. I think if everybody continues to socially distance, pay proper attention to hygiene, and I include the people who work in hospitals in that group, because I'm sad to say that often I think that we're not really showing the best example we ought to the community at large when you see some pictures of hospital staff. But I think that if we can do our very best, we can at least prevent the situation, as far as waiting lists go, from worsening significantly this winter, because we cannot allow things to worsen because of all of the knock-on consequences. So I'd like to think we can get by with isolated outbreaks.
Ben, last thoughts from you, and then Hannah.
Yeah, no, I think Derek's made some key points there. I think we're going to be better. We have to be better. We're not going to have to go through all this protocol sort of design and delivery, because we have it. However, my urge would be that, as someone who does, some, benign and some cancer work, let's look for reasons to try and be more efficient. One of the things the NHS has not been good at generally is efficiency. And anyone who's done a list recently will realize that it's hit new lows, because there's a reason, because of COVID, why X, Y, and Z can't be done. Sending for the patient, collecting them, everything. Let's look for reasons as a team of people who work in the NHS to try and do more, not less. Let's be a little bit more driven. Let's be there on time, because we owe it to these poor patients who've been waiting for months and months for these procedures to try and within reason to get the most we can out of the system safely. Great.
And Hannah, last thought from you.
So I'd just like to echo that idea of trying to find solutions and staying positive. In urology, the urology section of the Royal Society of Medicine have really made a big difference to trainees by running a Zoom series of webinars, accessing world experts from the US, Australia, the UK. It's really innovative. And I think as we all get used to communicating via Zoom, why can't we access the best people from around the world to do that teaching? So thank you to the RSM for putting that on. And I'd like to encourage other specialties who maybe haven't made use of that technology to do so.
Well, thank you very much. So it's time now to finish. Thank you to our three guests, Derek, Ben, and Hannah. Really, really interesting hearing from the actual coalface what's going on. I think our audience would have enjoyed that. So just a few last things to say. Next week, we'll be covering long COVID this time next week. So do join me for that. I'll be chairing that with three expert panelists. On Wednesday evenings, we have our more relaxing conversation series. And yesterday, we asked Trevor McDonald, the newsreader from the News at 10, and that will be available on YouTube as of tomorrow, I hope, or certainly next week. Next week, we have Lloyd Grossman, famously from MasterChef, author of a new book about Rome, and which is, I've just bought a copy. I haven't actually read it yet, but I will have read it by next Wednesday. So do join me for that. And just a final reminder that we'd love it if you're not a member of the RSM, then you can fix that by joining up, because the more members we have, the stronger we are as a group, and we have great prospects of enhancing the activities of the RSM over the next few years. I'd also like to say that because of COVID, we've heard the impact of COVID on surgery, but COVID's had a bad impact on the RSM as well. We've had to close our building for 6 months, so our hotel, our restaurant, our conference centres have all been closed. So if you're feeling very generous, or if you happen, like Hannah, to know any millionaires who'd like to support the Royal Society of Medicine, all donations will be very gratefully received. So have a wonderful day. The weather is absolutely beautiful here, and I think it's beautiful in Northumberland as well. So thank you, everybody. Thank you, all our listeners and viewers, and have a good afternoon. Bye.